Hello, I'm Alan Weil, Editor-in-Chief of Health Affairs. Thank you for joining us for today's Policy Spotlight with Liz Fowler. Policy Spotlight is a series of virtual events Health Affairs holds featuring in-depth conversations with influential health policy experts. I've had CMS Administrator Chiquita Brooks-LaSure, FDA Commissioner Bob Califf, White House COVID-19 Response Coordinator Ashish Jha, and many others on the program. And it's great to have Liz back for actually our second time. We spoke about, I think about 15 months ago. All of our policy spotlights are recorded and they can be viewed on the website. I would note that today's edition of Policy Spotlight is also part of our ongoing age-friendly health series sponsored by the John A. Hartford Foundation. We're appreciative of their support for the series and their support for making this event possible. If you're watching us live, you do have the opportunity to ask questions through the Q&A box at the bottom of your Zoom screen. I will do what I can to build those questions into the conversation. It helps if they are of general interest, and if you can keep them shorter and get them to me in the earlier part of the event, more likely I'll be able to weave them into our conversation. But we do like making sure that we're asking questions of interest to our audience. So I'm so happy today to be joined again by Liz Fowler, Deputy Administrator, Director of CMMI, the Center for Medicare and Medicaid Innovation in the U.S. Department of Health and Human Services. The Innovation Center designs and tests different payment and delivery models designed to improve quality, lower cost, and promote patient-centered care. In 2021, CMMI had a strategy refresh with new strategic objectives. We'll certainly be talking about those in our conversation today. As I noted at the outset, this is part of our series around age-friendly health, and a significant portion of our discussion today will focus on the GUIDE model, Guiding and Improving Dementia Experience. That is going to probably be about half of our time, but I do also want to leave time for other innovations occurring at CMMI and give Liz an opportunity to tell us about some of the other exciting things going on there. Before coming to CMS, Dr. Fowler was Executive Vice President of Programs at the Commonwealth Fund, Vice President of Global Health Policy at Johnson & Johnson. I met her way back when she was Chief Health Counsel on the Senate Finance Committee. And there have been other roles in between. She has a bachelor's degree from the University of Pennsylvania, a PhD from Johns Hopkins University, and a law degree from the University of Minnesota. Liz, we've had the pleasure of working together over the years, so I hope I can call you Liz, and you should call me Alan, and really looking forward to getting a chance to talk to you again. I think as we get started, as I mentioned, I know we'll be putting a particular emphasis on GUIDE, but since it has been about 15 months since we spoke in this format, I'd like to just give you an opportunity outset to tell us a little bit about what's been happening during that period, what some of the priorities are, and I know GUIDE will be on the list, and we'll start there, and then we'll turn to some others.
Oh, thanks. Well, first of all, let me just start by saying thanks, Alan, and thanks to Health Affairs for putting this event together and giving me the opportunity to speak with you today. It has really been a privilege to lead the CMS Innovation Center at a time when we've had the opportunity to look back on our lessons learned and chart a path for value-based care in the next decade. And we've made a lot of progress since the last event, the last time I joined you. You mentioned the strategy. We did put out a strategy white paper and talked about building a healthcare system that achieves equitable outcomes through high quality, affordable person-centered care. We laid out 5 objectives. First, drive accountable care that promotes delivery of whole person integrated care. We set a pretty bold goal for every Medicare beneficiary and the vast majority of Medicaid beneficiaries to be in an accountable care relationship by 2030, where a provider through an ACO or advanced care practice is responsible for total cost of care and quality. Advance health equity. We committed to embedding health equity into all aspects of our models, from design through evaluation, including a focus on safety net and rural providers that care for underserved populations, data collection, including social drivers of health. Support innovation that enables delivery of person-centered integrated care. These are the tools, the data, the flexibilities that providers need to deliver care that's consistent with what people really want out of the healthcare system and their goals and preferences. Affordability, our statute says we should focus on program savings, and of course we are committed to that goal, but we also want to think about affordability for the beneficiaries we serve, and then finally partner to achieve system transformation. Medicare, CMS can't do this alone, and so we need to collaborate with other payers, including states, commercial insurers, and employers. We've provided an update on the progress of our strategy and laid out metrics for success on the goals we've set. We have announced a strategy to integrate specialty care and primary care. We have put out a report in response to the President's executive order on prescription drug pricing, outlining 3 new potential models. This summer, we've announced 3 new models. I know this is a long list and you're probably wondering when I'm going to stop talking, but I'm almost done. The Making Care Primary model, or MCP, the Guide model, which you mentioned and is the topic of today's discussion. And then just last week, we announced the state's Advancing All-Payer Health Equity Approaches and Development model, or HEAD model. In sum, a lot of really exciting progress since the last time we visited, and really hoping that we've provided a clear direction on where we're heading, and that we've helped really reignite interest and enthusiasm for value-based care. And maybe one last point to make is that another difference from the last time I was part of this broadcast was when I was working from home, and now we're back in the office. So my background and setting is a little bit different than last time.
That's a great note. I have to say you're catching me from home today, but we're becoming a little more hybrid as well. Well, terrific. So as I noted, we marketed this and planned this to have a deep focus on Guide. And you know, when I think about it from where I sit, and I think about the health affairs audience, there are resources on the website. You've posted the model and some FAQs and other kinds of things like that. I don't want you to just read those. I would ask you to provide a little bit of just sort of context for what it is and what makes it unique. But I always like looking a little bit under the hood. And so to me, it's sort of interesting to learn, how did this come into being? What prompted the work on this? What steps had to be taken to build a model sufficiently robust? And of course, we're in the business of evidence creation. What kind of evidence did you have, and did you feel you needed in order to launch this? So those are some of the questions that I'm going to get into. But why don't we just start, if you don't mind, for those who haven't scoured the website or aren't deep into dementia care, say a little bit about what the model is, and then maybe jump into how it came into being.
Sure. Well, I'll start by saying we, in short, we really felt like care for people living with dementia and their caregivers was an area of great need, but it wasn't one that the Innovation Center had spent a lot of time talking or thinking about in terms of solutions. And, you know, we know nearly 7 million Americans currently live with Alzheimer's or dementia, and that number is growing rapidly. We know that the toll that dementia can take, physical, emotional, and financial, on those living with the condition, but also their loved ones who care for them. And that there are a lot of areas of fragmented care that really impede the ability to deliver better care for these for people living with dementia. And so we wanted to address existing gaps by defining a standardized dementia care delivery program, providing an alternative payment methodology, addressing caregiver needs, and paying for respite services. And so, and it was partly, you know, the President's landmark executive order on increasing access to high quality care and supporting caregiver that gave us sort of the wind beneath the sails to really push this out as quickly as we can. But it's about trying to facilitate a better quality of life for people living with this condition and help them remain in their homes and communities longer. In terms of how it's unique, I'll just say a few things and then maybe turn to your in-depth question on how it came about. This is a voluntary nationwide model in which participants will establish dementia care programs that provide ongoing longitudinal care and support to people living with dementia through an interdisciplinary team. The model is really unique in a couple of different ways. First is the way that it acknowledges and addresses the role that caregivers play in the lives and health and outcomes of people living with dementia. Participants in the model, and we can talk a little bit about who's who we envision as participants, but they have to identify a primary caregiver and do an assessment of that caregiver's needs and capabilities. They must offer caregiver support training, assign care navigators to coordinate all of the care, and then provide access to those respite services. It's really the first model to target reductions in federal spending on long-term nursing home placement. And that's a metric that's not only important to achieving savings, but also really a key person-centered indicator of quality improvement. This is a longer model than usual. We've said that it will run for 8 years. And that's because the goal is really to delay long-term nursing home placement. And 8 years is really the time you need to detect the effects on long-term nursing home use. Because of that progression from mild to severe dementia can take some years. So in terms of the process, like I said, we identified this as an area of unmet need. And we also got a direction from our CMS administrator, Chiquita Brooks-LaSure, and she directed us to explore the feasibility of testing a dementia model after the idea was raised in a roundtable with patient advocates. And I think maybe a pivotal point in that model development after being given that instruction was our participation in a day-long roundtable that was organized and hosted by the John A. Hartford Foundation and the Education Development Center. They pulled together more than 50 leading researchers and practitioners in the dementia care space. And we heard not just from experts, but also a patient advocate who's living with dementia. And she really helped shed light on that lived experience and what it took to get the care that was needed in order to make meaningful improvements. And it's that patient perspective that really led to thinking about what a model could look like. If you're interested, I think Allen Health Affairs published a paper that was summarizing that event and the key takeaways. But in addition to the roundtable, we collaborated across the department. There are a number of agencies and parts of the department that focus on dementia care and care for older adults. SAMHSA, Administration for Community Living, National Institute on Aging, HRSA, Assistant Secretary for Planning and Evaluation, ARC. All of our colleagues all had a role in thinking about that. And this model really, the model team that worked on the model used all of these cumulative learnings to create a patient journey map that really looks at what care looks like today, what we would want to improve, and how we would go about that. So you can find that journey map on our website if you're interested. So that's a little bit of the backstory.
It's great, and I'm very interested in sort of how it came into being. The questions are starting to pour in, and I of course have some of my own, but let me just try to navigate a few of them at this point in the conversation. So I'm sure anytime someone comes up with a model, there are 100 questions about why this, not that, but I'll ask a couple of them and related a little bit to some of the topics I teed up earlier. Obviously, dementia is a huge issue for the population you're trying to serve, but there are also a lot of other very high need, high cost Medicare beneficiaries, including those who have, functional impairments that are not dementias, who probably could also benefit from these services. So one of the questions that came in from our audience is sort of why just dementia as the condition, given the other people with similar needs?
Well, it's a good question. And I think if we prove the proof of concept and we start seeing that this works, I think that is a possibility to look at expanding to other populations in need. But you have to start somewhere. And this was a population that we felt was not represented well in our models. And it also fit very well with our strategy. Some of the key pillars in our strategy. It's not a total cost of care model, and as a number of our models are, but it is something that we felt could also work well with an accountable care organization, for example, either something that an ACO or advanced primary care practice could jump into, or it could be a standalone as well. So there were a number of features that seemed to make sense and really supported our strategy.
So actually, I wasn't going to go there, but since you mentioned it, and you said it in your opening notes as well, talk about who you do see as participants.
So there's two tracks, one for existing programs, and those are established dementia care programs, many of whom are based in academic medical centers, for example. The other track, and maybe the more interesting part of the model, is really it's for providers and practitioners to come together to form new dementia care programs with their existing practice, or they can create a separate entity. And we're focused on recruiting and outreach efforts to encourage this new program development. And we think that those new programs could be the majority of model participants. I mean, obviously we'll have to see.
So, as a journal, we're very interested in evidence and the sort of sweet spot for CMMI. This is one of those sort of philosophical questions, but I've known you long enough to know that you think a lot about these. On the one hand, the whole premise of CMMI is that you're somewhere on the learning journey. You don't know all the answers, or else we wouldn't need an innovative model. We'd just be doing it. But you want to have sufficient evidence at the outset that you're doing something that is likely to uh, attract interest among participants and also yield benefits. You also mentioned some dimensions of this that are unique: the longer duration, the involvement of caregivers, the quality metrics. So I'd really love to hear some more thoughts from you on how you approach how far along we need to be in the evidence, and how confident you feel, or where you feel the evidence is strongest in terms of the model's likelihood for success, and where you think the learning is going to be greatest.
That's a great question. And you're right. I do spend a lot of time thinking about that, because I think if you look at the history of the Innovation Center, out of the 50 plus models we've had in the field, only 4 of them have been certified for expansion under the definition of the statute. But we think that the impact has been much broader and much greater, the impact of our models, and that it's not really captured in the way that we're thinking about this sort of net savings. I think also, and this goes to why we looked at a longer model. Most of our models have been 5 years, and if you're looking at trying to demonstrate savings for a voluntary model in 5 years, and you're really looking at areas that have been underinvested, rural healthcare, primary care, underserved areas, it's really hard to generate that savings. And so that's part of why we looked at a longer model. I think we're, in terms of where we hope really to see an impact, is really keeping people at home and in the communities where they live. I think we really want to look very closely at caregiver burden and whether or not we've been able to alleviate the burden on caregivers through respite services and other benefits of the model. And all of this, I think we hope that, total per capita cost is going to be lower than it would be if you weren't in the model. A lot of that, obviously we'll have to see, but we're very hopeful that we will have positive outcomes. I can talk about the other performance measures if you're interested. Use of high-risk medications in older adults, quality of life outcome for people with neurological conditions, and then again, long-term nursing home stay, caregiver burden, total cost per capita. But it's the caregiver burden and the long-term nursing home stay that I think those are the newer metrics that we developed for use in this model, and we're very keen on testing.
So I have to say, I'm being inundated with questions, which is wonderful. It also means we're not going to get to them all. And it also suggests to me that some of them are quite technical about the application. And I think this isn't a TA session, but I'm just giving you that feedback that there are a whole lot of questions, which I take as a good sign. One that I do want to weave in, I think you may have already answered it, but I think it's phrased nicely, is, do you see supporting care partners primarily as a way to reduce placement into long-term care settings, or are you also looking at improving the well-being and reducing the the harms to health of care partners as an end in and of itself?
what was the second part of that? I'm not sure I
So I
got.
think really the question is supporting caregivers designed to reduce institutionalization, or is it designed to support caregivers?
Oh, I think
Uh,
it's both. I think
I
it's both.
assumed that was the answer, but I thought it was a great
Yeah,
question.
that is a very good question. We think there's a lot to be said for supporting those caregivers and want to do it in a way that we're actually able to measure and demonstrate.
So, as you know, my background is in Medicaid, and I think a lot about the role Medicaid plays in sort of building delivery systems for high need populations. Um, and we have at the state level, I shouldn't say we, it's been a long time since I've worked for a state, but when I look at Medicaid agencies, there's a lot of effort that goes into to sort of crafting the elements of an effective model and figuring out what levels of support and tailoring to conditions even in a state and sometimes regions within a state. And I don't think of Medicare as having quite as clear a picture of what's on the ground in terms of service opportunities, supports, who the providers are, what roles they're playing. And then I realized, well, of course, again, if you go back to what CMMI is all about, it's designed to help you test those kinds of things. So I'll come at the question sort of from two dimensions. One is just sort of what's the role of Medicaid? When I think of dementia care, I think of Medicaid, and I wonder how that fits into your thinking. But I also wonder about the building of systems, and you talked about who the providers might be and what sort of assistance and resources might be available to them in addition to just a payment model.
Yeah, Alan, that's a really great question. So first, Medicaid programs or Medicaid agencies wouldn't be participants, but we hope that they would be partners and that they would be able to support and work together with some of the participants in the model. As you said, this is really designed around a Medicare model, and we're thinking about respite services. So it's, there might be some overlap, but I think we're trying to stay separate and clear in terms of the population and in terms of the services. I think what we don't want is an overlap or, sort of a confounding of Medicare and Medicaid here. And frankly, if we are able to provide this set of services and care for people that are in Medicare, maybe they don't end up, having to become impoverished and needing to rely on Medicaid for some of these services and benefits. And coming out of this, perhaps we're able to make recommendations for, a recommendation to Congress for what Medicare should be covering that would support these populations and being able to keep, a lot of the folks that we're talking about in their homes and communities.
A number of questions about sort of, again, this is both a larger conceptual question and a smaller technical one about the layering of value-based payment models on the fee-for-service side of the Medicaid program, while there are also, as you mentioned, total cost of care approaches. There obviously half the enrollees are in Medicare Advantage. So as you, and a number of the early questions that came in were, how many more models are we going to get? So as you think about sort of the size and scale and the relationship across the different kinds of payment approaches, and you're at the very beginning, your comment about moving everyone into accountable care as a priority, how does this fit within that?
It's a great question. And I think one of the points that we made when we rolled out the strategy is that we wanted to do fewer models, and the models that came out, we wanted to make sure that there was a clear understanding of how all the pieces fit together. So as I've described it, when CMMI was, got its start, it was natural to let 1,000 flowers bloom and throw a lot of spaghetti against the wall and see what sticks. Like, we didn't know what worked. I think we have a better understanding of what works, and that's what's reflected in the strategy that we outlined. This model is designed to be compatible with other CMS models and programs that provide healthcare entities with opportunities to improve care and reduce spending. So it's designed to allow for flexibility and overlap of providers and beneficiaries. So ACO organizations can come into this model, including shared savings, including the practices that are participating in ACO REACH, and it was intentionally allowed to have that sort of potential for integration. But we are doing fewer models now. I think we're being very deliberate about the direction we're going. And when we do put out a model, it needs to fit within the confines of our strategy and very clearly articulate how we're furthering the goals that we've outlined.
And someone asked about the relationship to Medicare Advantage. I assume there is none. This is not
That's
an
true.
MA.
This is not an MA. So so it's firmly rooted in fee for service, and I probably should have said that. So if you're part of an MA plan, including a SNP plan or a PACE plan, you're not able to come into the model. I mean, that there would be a lot of overlap, and
Yes.
so that makes sense.
So again, I'm sort of oscillating among different types of questions, but as a journal, we also are looking at the endpoint here in the evaluation. You talked about some of the outcomes you're hoping for. As with all voluntary models, you have selection challenges. You have selection on the part of which providers are going to participate, but you also have it among the patient enrollees, and particularly dementia, which can range from quite mild to very intense. And how are you thinking about both sides of selection, patient enrollment as well as provider? And how are you thinking about whether selection is a big concern at this point, or really at this moment you're just trying to do more what I might think of as proof of concept than actual sort of dissemination of a model where selection would be a big concern?
Well, those are really important questions. And as you can imagine, if you can picture our evaluation team thinking, well, this should be randomized. Let's have a randomized design.
I can easily imagine that.
You can imagine the conversations we were having behind the scenes, like, well, it's really hard to think about how you randomize, people living with dementia into like, you get the respite benefits and your caregiver doesn't. And that just didn't feel comfortable. So, I mean, we have a voluntary model, and that brings with it certain challenges in terms of the evaluation, but we've got a team that's given all of these questions a lot of thought. I think also another related question is how we're thinking about equity, because, as you know, and there are disparities in who gets care and in who's diagnosed. And so really thinking very closely about how to make sure that all patients have access, and that all providers feel like there is a pathway for them, including those that serve underserved populations. So we've got a requirement to develop and implement a health equity plan that identifies disparities, strategies to reduce those disparities. Participants are going to be required to collect and report on socio-demographic characteristics. And as I mentioned, we're now collecting health-related social needs. Obviously, beneficiaries can have the option to opt out, but of some of this data sharing. But for the sake of making sure that we're representative, we've got a representative sample. We hope that we'll have enough data, information, and participants to be able to draw conclusions about some of these things.
And given the longer timeline, partly you explained that as a way to improve the odds of finding effects because it takes time. But does it also, are you envisioning tiered enrollment by participants so that you could actually, some of the providers who maybe don't feel like they're ready yet, but they start seeing this develop and they say, oh, this is something we could do and we want to come in a year or two from now. Is that part of the thinking?
It is. And those two tracks, the established programs and the new programs, we have two different start times. So really thinking about a longer sort of implementation period so that new programs can sort of get up and running and establish the relationships with community-based organizations and the strategies and approaches that they'll need to have in place to be successful in the model. So they'll be starting that second track will start 1 year later. So the existing programs will be able to start July 1st, 2024, and then the new programs, they can have that sort of pre-implementation period in that year to get all of their networks up and build those relationships, and then the actual performance will start in 2025 instead of 2024.
We talk a lot in healthcare these days about risk, and there's financial risk. There's lots of other risks as well. Obviously, if you implement this and no one participates or there are no positive outcomes, that would be very disappointing. But are there downside risks here that we should have in mind, particularly around enrollee protections or around financial risk that providers might be taking that they may not be prepared to bear?
So this is not a shared savings model. So this is not a put you at risk, and if you're not doing a good job, then you've got to pay back the funding. That's not how this model works, unlike some of the other models that we lead. So I think it's just a different approach. But good question. Another good question.
So I really appreciate that answer, but it does leave me sort of wondering I don't mean to spell out doomsday scenarios here, but sort of what's the worst that happens here? Maybe that's not the right way to think about it, but it is the question that crossed my mind.
Well, it's a good question and won't be any surprise. And by the way, this is why it takes so long for a CMMI model to go from soup to nuts, from the time we start working on it until we actually get it out the door. We've got a lot of discussions with our actuaries, with the budget folks in the Office of Management and Budget, who all ask those questions like, well, we don't want to open the bank of Medicare funding, without knowing that we have a chance of developing a model that would generate potential or has the potential to generate savings. And so we've gone through a pretty extensive review, and if it looks like it's not working and it's not generating the savings that we expect on the sort of the long-term nursing home side, or the other aspects of care that we expect to see potential savings, they'll call into question, I'm sure, like, let's have a conversation about the model and its future. But I think we're pretty confident, and I think the way we've designed it and the way that we've worked through these questions with our experts, we think that we have a pretty good chance of generating potential savings. Now, again, this is why there's an 8-year model instead of a regular 5-year model. So do we think we could generate those savings in 3 or 5 years? Probably not, but that's why we're aiming for a longer time period to generate those returns.
So you alluded to equity, of course, as part of the central framework for CMI, for CMMS as a whole. And I'm wondering what dimensions you're thinking about. We obviously often start with questions around racial and ethnic equity. Someone asked about other subgroups that might be relevant to study. Their specific reference actually was to co-occurring mental illness or intellectual developmental disabilities. But I just wonder, you mentioned early on a focus on rural. Are there other dimensions that you're particularly keeping your eye open from an equity perspective as this model rolls out?
I think geographic diversity, equity in terms of race and ethnicity, all of those factors I think are probably front and center. As you know, it's not always easy to collect and find data. And so I think the more specific you get into some of these categories, you run the risk of potentially not having accurate data. I think we're interested in all of the above, but really I think equity, as we think about it, is defined in the CMS definition of how we're trying to advance health equity. I will say we do have the ability, and I think this is a recent tool, and give a lot of credit to our learning and diffusion group within the Innovation Center. We can now look at who's applying to come in, and we can map that against the area deprivation index and really see to a very specific level if we're really bringing in that geographic and underservedness in terms of who's coming into the model, and it suggests that we could then go into other areas and maybe do some outreach, some targeted outreach. But again, it's probably not reaching some of the populations that were named in the question. But if there are things that we should be thinking about and strategies we should be thinking about, please reach out. I think we're open, and we are committed to these issues and would be open to recommendations and suggestions.
And there have been a number of questions about sort of the pharmaceutical side of this, the new drugs. I'm not seeing an obvious sort of interplay here, but I'm sure it's something you've given some thought to. So I wonder if you could say a little bit about that.
Yeah, I mean, this is a payment model for care delivery, a care delivery approach, and the caregiver support approach. Some of the patients may be, eligible and benefiting from pharmaceutical solutions, but that's not an explicit part of the model.
Okay. Well, look, I still have a huge number of unanswered questions that I couldn't get to. I just will provide them to you just as feedback to give you so you have a sense of the kinds of questions. Again, this isn't a TA call, but it's striking to me how much curiosity there is, and they really range from everything from sort of operational questions to many questions that I think go back to this sort of philosophical one that you, of course, have to deal with on a much more practical level, which is the interplay across these models for people out providing care and trying to figure out what they're operating under and whether to take advantage of a particular voluntary approach and how it aligns with other parts of their practice. And those are very specific, nuanced questions, very important that we probably won't be able to get to today. So I did promise that we would give you some time to talk about some other things going on. I think we're more than halfway through, so I do want to turn to a few other topics. I'm not saying we'll drop guide entirely, because it may well come back into the discussion, but I, as you might imagine, given my own background, was particularly struck by the very recent announcement about the state level AHEAD program. And I don't want to force you to pick that one over the other items of interest at CMMI right now, but I wouldn't mind sort of turning there first to just because it's brand new. Again, maybe to say a little bit more about it. And obviously it's very different in so many levels than what we were just talking about with Guide. But if you could tee us up, and I'll ask a few follow-up questions, and then we'll open again to some other priorities as well.
Sure. And let me say one last point on the guide model, and that is that we anticipate releasing the request for application later this fall, and more details will be available there. And I think we plan to have sessions, and I think there are opportunities to ask questions of the model team. So those who might be interested, I think we're accepting letters of interest. I think the deadline for that ends tomorrow, but more information about Guide will be available in that request for application. Turning to the AHEAD model, which is very ambitious and very exciting. It is a multi-state model that aims to curb rising healthcare cost growth, improve population health and health outcomes, and address health disparities, many of the same goals that we've outlined for the previous model we just talked about. The model proposes a very significant restructuring of health system spending across all payers in a state or region. So an entire state doesn't have to come in. It could be a part of a state, with increased investments in the type of care that is better correlated with improved population health and health equity. And that's offset by reductions in spending and utilization in other areas to constrain total cost of care. So this is a total cost of care model. We've been working on this model for several years, so really excited to be able to finally talk about it. It's extremely ambitious. It combines elements and lessons learned from multiple previous state-based models, including the Vermont all-payer ACO model, the Maryland total cost of care model, and the Pennsylvania rural health model. And also it's worth noting that although it aims to directionally align all payers across states or a sub part of a state, it's designed to be flexible enough to meet states where they are and support their ongoing transformation efforts in terms of outlining what are those areas of focus for population health improvement, for example. So we really believe that this model is going to be key to advancing the Innovation Center's vision of whole system transformation and transformation sustainability.
Well, we'll have to do a whole separate call on this. It's so new that I haven't even had much time to digest it, but it is nice to see something coming out that is that ambitious and has a very different feel to it. You know, this was some time ago. You will know this, not all of our listeners will, but I remember working on the State Innovation Model Program, the SIM program, that was, again, sort of the federal government taking an active interest in states wherever they were with the priorities that they were identifying, and then trying to support the kinds of policy environment that would make those likely to succeed. And this feels like that, at least at the very beginning. And we'll see. Oh, in fact, right as I was saying that, this must be a coincidence. Someone send in a question: what learnings from SIM informed the AHEAD model? So I didn't think of that, but it's a great question.
Yeah, it is great. And I think it sort of recognizes the importance of making sure that the direction reflects state priorities. So this isn't CMS saying, here's the 5 areas you need to look at, but really thinking about what those state priorities are, but also putting in sort of, from our perspective, that sort of accountability targets for all payers, and then the Medicare fee-for-service growth targets. We're also putting in very specific we're looking for primary care investment targets, as well as the population health outcomes. And it also includes hospital global budgets. So it's maybe SIM plus Maryland and Vermont and Pennsylvania. So.
I am struck that when we start talking about SIM and when we talk about AHEAD, the mental model, I think, tends to go to, if you will, the younger, healthier portion of the state, or alignment with the commercial population, a working age population. We've just spent more than half an hour talking about the GUIDE model and people with dementia, and yet those people are getting services from the same hospitals and many of the same other clinicians as in these other models. I do wonder, and I know we already had a bit of a conversation about the relationship between GUIDE and Medicaid, and I do understand that, but I do wonder how, when you're working with states, whether they're thinking through the entire range of population as they consider these models, and whether you're thinking, as you're anticipating proposals from states, whether they're taking into account also a population that may be more closer to the services that GUIDE needs than to what the younger people maybe on Medicaid are using.
Well, first, let me say that I started talking about GUIDE by saying, we identified this as a gap in our portfolio. We hadn't really done much with, for people living with dementia. It struck me, we did a webinar when we rolled out the new primary care model. I mean, there must have been 6 or 7 questions. When are you going to do something with pediatricians? When are you going to do something with children? And we've taken that back, and we've been, thinking about that as well. I will say and I do want to put a plug in for the Making Care Primary model. That is our newest primary care model that builds on our decade of experience of previous primary care models. But what makes this one different is we approached state partnerships very different. So we only went into 8 states where the Medicaid program agreed to be a partner and align the Medicaid payment systems. So how they wanted to think about that. So it really, instead of some of the previous models that might have been 26 states and maybe a light touch relationship with the states, this is what we think is a much deeper relationship with the states that are participating, and really thinking about how we can align both Medicare and Medicaid. And hopefully that makes it more likely that commercial insurers come on board as well. So those that model will be in Colorado, North Carolina, New Jersey, New Mexico, specific parts of New York, Minnesota, Massachusetts, and Washington. So that's different. I do want to make a point also that that model provides an on-ramp for safety net providers and small or independent primary care practices that might not have been part of previous value-based care models. And so we're really, again, targeting those who might not have come into previous models. And like Guide, it's a longer model. So it's 10 years instead of the usual 5 years.
So when you think about and describe that, I was going to turn to that one and you already did. When you think about the AHEAD program, I assume also at this stage you're thinking of a quite limited number of states that would have the appetite in the infrastructure. And so is that a fair assumption?
It is, and AHEAD includes a very specific strategy for primary care. So in the case of the Making Care Primary and the AHEAD model, those are not overlapping. So a state couldn't be part of MCP and AHEAD. They're sort of mutually exclusive. And AHEAD, it's a competitive process. So there's a notice of funding opportunity that will come out this fall, and we'll see what states apply. There's another opportunity to apply in the spring. So we can fund up to 8 states in the AHEAD model. So again, really thinking very carefully about who's ready to come in and then able to participate and has sort of the infrastructure in place. And depending on where a state is in its process of thinking about these very big questions and getting the system ready, there's quite a long lead up time to the model actually starting.
So I'm going to once again put my, journal editor hat on and say that the more far-reaching and statewide, although you mentioned it doesn't all have to be statewide, these initiatives are, the harder they are to evaluate. It's hard to have a counterfactual. You can pick, as people did in evaluating Maryland and Pennsylvania, they would pick neighboring states with what they viewed as similar characteristics. There's been long-standing debate, and we've published much on it, on the long-term effectiveness of the Maryland model and its many iterations, of course, over the years. How do you think about the evaluation side of something as potentially transformative as the AHEAD model?
Again, I think we'll be looking for those counterfactuals and identifying the difference that the model has made compared to maybe a similarly situated state. Our evaluation team has been giving that a lot of thought as to what that might be, depending on who comes in. I think that your question, though, sort of suggests a larger issue that we're grappling with, and it's something we're giving a lot of thought to, and that is, as value-based care becomes more prevalent, and more providers are part of value-based care, it's harder and harder to come up with that sort of clean counterfactual. And, what is the counterfactual to some of the models that we're testing, when maybe the control groups have also been experimenting around and looking down the road of testing or delving into value-based care. So it's getting harder and harder. And I think I would like to think that we're actually making a bigger difference than maybe some of these evaluations are able to detect. And I was really heartened to see the New York Times article that came out last week about how healthcare really has, the rate of growth has slowed quite a bit.
Just Medicare, not the rest.
Medicare has slowed, yes, but then what the role of the Innovation Center and some of these models and some of our approaches have been. And I don't think we can draw a definitive cause-effect relationship, so we're a little gun shy about saying that we've had that that definitive effect. But I think there has to be, we have to take credit for some of that, and I hear people starting to maybe be willing to give us some credit for that, even though on an individual basis, the model might not have come out at the other end and said, yes, you've demonstrated net savings to generate a certification
Well, we could talk about this a lot. I will restrain myself. I mean, first of all, let's just say that politicians have no hesitation taking credit for good things that happen on their watch, whether they had anything to do with them or not. So maybe we should all take a page from that. But in all seriousness, I think you're capturing so many dimensions of issues that we struggle with a bit, at a journal. What is sort of uh, the inner what are the multiplicative effects of having multiple initiatives out there that may be different from having one or another? What's the and what are the effects of just telling people that this is a priority and that pressure is coming if the system doesn't do better? And so I think all of these are dimensions that make it hard, but to return to the very specific one that you mentioned, I completely agree, which is we don't really have a counterfactual anymore. And including that when I talk to people and they talk about Medicare Advantage and Medicare fee for service, I even increasingly say, well, let's not call it fee for service. Let's call it traditional. I'm not the only one who says that, but I do think there's risk in referring to traditional Medicare as fee for service when there's so many alternative models within it. And then the question becomes, how important is it that we know exactly what caused what if things are moving in a direction that's favorable? Maybe that's enough to know. We're coming close to the end here, and I did promise our audience, and you of course knew we were going to spend most of our time on guide. I then pushed you to talk about the AHEAD program. You brought in the primary care models, but I do, before we wrap up, want to make sure you have an opportunity to raise any other areas that are of particular interest to you, of particular importance. Of course, a bunch of questioners are asking how many more models are there going to be? Are there mental health focused models? Are there this model, that model? To the extent you can tip your hand on those or show your cards, I'm sure people would be interested. But I do want to give you an opportunity to bring in themes that I haven't been able to in our time.
Well, I will say, and I am excited about our portfolio, and we do have a couple more models that we're hoping to be able to announce later this year. Some of it will depend on whether can I dare say it, whether the government remains open and the Congress finds a way to keep funding the government starting with the new fiscal year. But assuming everything goes smoothly, we do have a behavioral health model waiting in the wings that's going through clearance, and a maternal health model. And both of those have a heavy role for Medicaid. And the behavioral health model also looks at Medicare as well. So excited about those. And then I think the other part of our strategy that's really critical and is really a hard nut to crack, and that is specialty care and integrating specialty care with primary care. And we outlined a strategy last fall and talked about a 4-part approach. One of them is sort of keeping the momentum going with we extended the BPCIA, the bundle payments model, for another 2 years. We have talked about another episode model that we issued a request for information on that will help inform that model. We put that out in the summer, and we hope to put out a rule in our direction with that approach in the beginning of next year. And really, again, not just doing a model just to do a model, but really thinking about how that specialty care and those episodes would integrate with accountable care and with primary care. We're looking at providing more and better data to ACOs and advanced primary care practices to help them manage specialty care. So that's another part of the strategy. And then longer term, we'd like to think about how to move upstream and really think about, instead of episodes, which is when somebody goes into the hospital or gets sick or, has a procedure, can we avoid that altogether by having better integration and keeping people well? And so that's sort of the longer term part of that strategy. And I'm excited about that work. But this is just a fantastic team at the Innovation Center. And by the way, if anyone's interested in joining us, I always put that plug out. We're always looking for good people who want to delve into this work. It's a great team of really smart people, and we've got a lot of really exciting things going on, and would welcome chance to engage, whether if you don't want to come work for us, but you've got ideas, feel free to share them with us, and we have an open door.
Okay, before we wrap up, we've talked a lot about policy, but I have to ask, you came to this job with a tremendous range of experience. Tell me something you've learned in the 15, 16 months since we last spoke that was brand new to you, despite all of the experience you had coming in.
Well, and Alan, I think you mentioned I worked on the Senate Finance Committee on the legislation that created the Innovation Center. So sort of now coming back to this role, I have really come to realize that moving the health system in this direction towards health system transformation, towards a better system that cares for patients better and really has the right mix of incentives to coordinate care and help patients navigate and just have a better care experience. I've just decided it's a marathon, not a sprint. And so, anyone who was thinking this would be fast or easy, it was probably, and maybe I count myself among those, really come to realize you can make a difference, but it takes a lot longer than maybe initially expected. But I'm really enthusiastic and optimistic about the direction we're heading, and I'm excited about the models we've announced and have in the field, and really think we have a chance to make a tremendous difference.
Well, those are words to live by, and I agree with you on both fronts. It takes longer than we sometimes think, but there really is progress, and it's very gratifying to see it and to shape it. So I appreciate that answer. Well, as we come to a close, I want to thank you, Liz, Dr. Fowler, for taking the time to talk with us, for all that you do at CMMI, for sharing your thoughts and your insights. I do particularly want to thank the audience. I've never had this many questions, and I am very appreciative of them. I apologize I couldn't get many of them into the conversation, but I did the best I could, and it was great to see the level of engagement, and we will share those with you. To those of you watching, you might be interested in some other health affairs events. On Tuesday, September 26th, Health Affairs Insiders can join us for a journal club, where author Jessica Souza will look at the article Choosing or Losing in Behavioral Health, a study of patient experiences selecting telehealth versus in-person care. And the following day, we'll have a briefing on how the ownership and structure of healthcare entities affects clinicians and patients as part of our Practice of Medicine series. That event is open to all, but the first is Health Affairs Insider, which, unlike today's Policy Spotlight and the Practice of Medicine event, is only available to those who become insiders and gain exclusive access to events, email newsletters, and other content beyond the journal. You can sign up for Insider on our website. We'll have more events, I assure you, as the fall proceeds, and we hope you will join us for those. You can find all of those on our website. Thank you again, Liz, for being my guest today. Thank you to our audience for their active participation. And with that, today's Policy Spotlight is adjourned.
Thanks, Alan.